Welcome. My name is Peter Haubman. I'm a professor at Case Western Reserve University and uh, delighted to have everybody join us for the opening plenary for the International Conference of the System Dynamics Society on Societal Containment of COVID-19. And a special welcome to newcomers to the annual conference of the System Dynamics Society, and three excellent speakers we have lined up for the session. I also want to thank the program chairs, program committee, and especially Homework Consulting for sponsoring the thread. Let me say a little bit about the motivation for the session. It began in February and early March as COVID started unfolding, when it became clear there'd be a profound impact on the pandemic. And at the time, there was also proliferation of modeling and data visualizations. Unlike anything we've probably seen before, and just as one quick metric, within a couple of months, there are already about 20,000 repositories, public repositories and GitHub projects, both visualization and simulation modeling data, whereas up to that point, there had only been 11,000. There are now about 62,000 repositories. And while many were building their own models just to understand what was going on, there are also multiple efforts starting up, often with folks with little or no experience in building epidemiological models. And that might be fine if it was just academic exercises or things we're doing to cope. But from my conversations with folks, people are starting to use these models to inform a variety of local decisions in hospitals on how to order and what to order, organizations, and in some cases also dispute the scientific results of leading experts. Leading experts who had extensive experience not only modeling infectious disease over many years, but in previous epidemics, but had also learned how to communicate the results most effectively to the public and policymakers. For example, through the work of the Midas Network that our first speaker, Jeffrey Shaman, has been involved with. So we wanted to make sure that we were highlighting some of the best scientific work on modeling COVID-19 to inform decisions. As a reminder, this session is being recorded and open to the public. The format for each presenter to talk for about 20 minutes will be for a 20-minute talk followed by 10 minutes of Q&A. Please post your questions in the Q&A box, and we'll try to get to these in order. And so without further ado, let me introduce our first speaker. Our first speaker is Jeffrey Shaman, is a professor in the Department of Environmental Health Sciences and director of the Climate and Health Programs at Columbia University Mailman School of Public Health. He uses mathematical modeling and statistical models to describe, understand, and forecast the transmission dynamics of infectious disease systems and to investigate the broader effects of climate and weather on human health. He will present on his use of Bayesian methods, his team's use of Bayesian methods for modeling transition dynamics. Please join me in welcoming Jeffrey Shaman.
Thank you. I'm going to share my screen now. All right, so I'm going to talk, as it was introduced, about modeling the transmission dynamics of SARS-CoV-2, the causative agent of COVID-19, and talk about some of the effects of intervention on timing of the incidence of outbreaks of this disease. I'm going to first acknowledge collaborators. A lot of this work was driven by Sen Pei. Dr. Sen Pei is Associate Research Scientist in my group, and many of the other collaborators are listed there. Dr. Ruyan Lee, who's based out of Imperial, also spearheaded some of the work, some of the data collection that led to the collaborations that you're going to hear about here. Also, I'm going to acknowledge my funders up front, otherwise I will forget to do so. I'm going to start by telling you actually about a prior project, actually, because this is what really informed our thinking and allowed us to take on study of this virus the way we did. This is a project that was called the Virome of Manhattan that was funded by the US Department of Defense. And what we were trying to do here was to understand a number of the characteristics of respiratory viruses that allow them to get around so efficiently and so well in the broader world. One of the main aims we wanted to do was try to understand how what kind of levels of asymptomatic infection were going around, what level of undocumented infection there was in the broader community for common respiratory viruses. The reason for doing this is that in most countries in the world, respiratory viruses surveillance is carried out in a passive fashion. That is, we wait for people to come seek medical care at clinics and hospitals, and then those people are reported to public health agencies. So all we get is only a limited view of what's actually going on with infectious diseases, respiratory diseases in this instance. We're only getting a picture of those who are sick enough, severe enough, that they're motivated to go out and see a doctor's care. And what we wanted to do was try to break through that and try to understand what are the broader presence and prevalence of the virus in the community. What levels of infection are there beyond what we're seeing among those who are seeking clinical care? So as part of this, one of the arms of this, we established a cohort where we had over 200 participants in it from October 2016 to April 2018. You can see that they were scattered within New York City among daycares, the Columbia University Medical Center, a pediatric and adult ED. This is the hospitals and, the doctors, nurses, and orderlies who worked in those institutions, as well as the teachers and students in a high school. What we'd ask from these individuals was to provide a diary, if you will, a daily report of symptoms. These are common cold questionnaire symptoms, things like sneezing, runny nose, cough, sore throat, chills, etc. They would rate 9 of these symptoms individually on a Likert scale, none, mild, moderate, or severe. They'd enter it on their phone. It would take them all of 20, 30 seconds. It would go directly into an electronic database that we maintain for each of these individuals. So we're getting daily symptom scores from them. In addition to giving us symptoms, they also told us on a daily basis whether because of the symptoms that they were experiencing that they had taken medicine, stayed home from work or school, or gone to see a doctor. Furthermore, once a week, regardless of how they felt, we would take a nasopharyngeal swab from each of these participants. We'd take it back to the lab and we would test it for 18 different viruses. So we also got a time series of infections, and we could see infectious episodes where an episode is defined as 1 or more weeks consecutively in which a person was shedding the same virus. Then the table in front of you, which shows you the outcome of this branch or this arm of the FIROM project. We've grouped the viruses, the 18 of them, into their broader categories. So the different types of flu are combined, different types of RSV are combined, et cetera. And you can see that there's 7 different flu virus types we have there. And you can see the number of episodes. And this included endemic coronaviruses. This is not SARS-CoV-2, but the endemic coronaviruses, things like OC43 and HKU1. There are 137 infection episodes of that versus 32 of flu. If you look at the next column to episodes, MA, that is medical attention. These are the number of times during an infectious episode that an individual actually sought medical attention. And you will see in probability of seeking medical attention, given infection with virus I, that the numbers there are in the lower portions. The highest one is influenza, where we saw that 22% of people, when infected with flu, sought a doctor's care. You can compare that to the endemic coronaviruses, which are fairly wimpy. And in that instance, only 1 in 25 infections persons would go to see a doctor's care. What we're seeing here is that the vast majority of infections are undocumented. They're not seeking clinical care, and they are unknown. And this is actually a better dividing line than looking at symptomatic or asymptomatic, because one of the other things that we could see from this study was that different people reported different symptoms. They had different baselines that they work at. The idea that somebody is asymptomatic, which we hear a lot about and discussed a lot, is not really clearly defined, which is a little weird because asymptomatic should be just without symptoms. But the reality is that some people report symptoms every single day. Maybe they have chronic rhinitis, maybe they have fibromyalgia, maybe they're just a hypochondriac, but they will report symptoms every single day. And there were others in our cohort who never reported symptoms no matter how bad they felt. So as a consequence, the dividing line between symptomatic and asymptomatic is a bit blurred and it's a bit hard to point to. But there's a very clear dividing line between documented and undocumented infections that is borne out by whether or not an individual goes to see a doctor. And it's only if you go to see a doctor that you can actually be recognized as having an infection. So that brings me to COVID-19. When this emerged in January in 2020, and we saw it spreading, at least at the point in time in early January 2020, when we began to get case reports, when we saw what was going on in China, and we see the Wuhan as the epicenter, we saw that it was very rapidly spreading to other cities within China. Furthermore, it was also getting on airplanes. We could see it move to Thailand, we could see it move to Japan, to South Korea, to the US. And we immediately suspected that in order to sustain that level of movement, in order for the virus to get around, it may be doing what the common respiratory viruses were doing, which is it was making the majority of it, people who were infected with it, were undocumented. They weren't severe enough in their infections to bother to go see clinical care. And this is a very important characteristic that allows these viruses to persist. Because what happens with a typical wintertime infection, at least for those of us who live outside the tropics, it's a wintertime infection, for something like the flu or an endemic coronavirus, is we typically don't do anything. We still go to work, we still get on public transportation, we still go to restaurants. If we have a business trip, we'll still get on an airplane. This allows us to move these viruses around in the community. It allows them to persist. It allows them to spread from individual to individual because we're taking them out and about, we're shedding them broadly in the community. And it's that facet of those common respiratory viruses that I showed you here in this table that really enables them to persist and get around in the community. That's one of the lessons we learned from this. So when we saw the rapidity with which this virus was spreading within China and then hopping on airplanes and moving from country to country, we immediately suspected that it had this characteristic, this ability to get around because there were lots of people who were unknowingly spreading the virus because they were unaware that they were infected with this novel agent. So what we did is we set out to try to estimate what the rate of undocumented infection was for COVID-19. We built a metapopulation model, which is a model that represents the transmission dynamics in a compartmental form in different locations, but links those locations up. In this instance, we were representing it in China for 375 cities. We linked the movement between the cities of individuals using location-based service data from Tencent, which has very large penetration into the Chinese market through apps such as QQ and WeChat. And we did this during the run-up to the Chunyan Spring Festival. The entire system is coupled with data assimilation methods, which are Bayesian inference methods, which allows us to ingest daily observations from all 375 cities and adjust the model and make estimates of critical parameters within the model, which is what the exercise that we're ultimately trying to do. Now, we simulated from January 10th to January 23rd. This is during an early portion of the spread of the virus in China as it really moved about and just started to hop on airplanes and move to other countries. We chose these dates because prior to January 10th, there's not enough signal. There's just too much sporadic incidence of cases that have been reported. And by January 10th, they're robust, so that's our starting point there. We have enough of a signal. We stopped at January 23rd because that is the date that China imposed travel restrictions out of Wuhan. They shut it down, and then they very quickly shut down travel in much of the rest of China and issued shelter-in-place orders that basically put 800 million people inside their houses. Now, the other feature of this model is that we're separately modeling documented and undocumented infections, and we're going to try to estimate what proportion of infections are documented, are going to become confirmed cases. Further, we're going to model the contagiousness of these two groups separately, and we're going to allow undocumented infections to be less contagious than documented infections if that's what's actually borne out. So there's allowed to be a differential that can also even be more contagious, as it were, but we allowed the model to estimate what's actually going on with that. Now, before we actually apply this type of system, which is nonlinear and is fairly high dimension, to the actual data, we undergo a synthetic test where we take the model by itself in free simulation. We impose initial conditions and a set of parameters, and there's 6 parameters in this model, and we integrate it over the 14-day period. We take that output and we feed it into the full model inference system and see if it can reconstitute and correctly estimate the 6 parameters that we're going for. And what you see here is one such example of it, where the red lines are showing you the true values that we put in for the 6 parameters within the model. And the blue shows you the estimations, the posterior estimates of those 6 parameters for this individual simulation. And you can see in all 6 instances, we're capturing the actual truth within it, We did this for many combinations of the parameters, and we also broke the model down to find out at what point it wasn't able to actually capture it, didn't have sufficient information. And we found that the system was identifiable, no matter what we put in there, so long as we were using the full complement of 375 cities linked with travel data, that we were able to actually identify the parameters within the model. So once we did that, we then stepped back and we put in the actual data. We use the real data, and this is the results of that exercise. The two things I want you to focus on are alpha and mu. Alpha is the reporting rate, and this is going to be the fraction of infections that are confirmed cases. You can see it's estimated at 0.14. So that means we're estimating that 14% of infections during this 2-week period in China were documented, meaning 86% were undocumented. Now, again, this period was prior to the controls that were imposed on January 23rd, and it represents the movement of the virus through Chinese society in its natural state, if you will, before there was real movement by the government and the public to do something about controlling the virus. So we're seeing that only 1 in 7 of the infections is actually being documented as a confirmed case. 86% are unknown. We also estimated this mu factor, which shows that per person, undocumented infections are on average half as contagious, roughly, as a documented infection. We also got a basic reproductive number of 2.38, which was in line with other estimates made at the time for what was going on with this virus. We could then take this model estimates, we could plug it back in, we could conduct free simulations. This is a plug and play mode, if you will, and see whether or not we could reconstitute or estimate correctly the actual observed outbreak by those parameter estimates. The observations are the X's here. The box and whiskers show you the daily estimates across 100 different simulations with the stochastic model using the estimated parameters. And you can see that we're capturing the growth in national daily cases, in Wuhan City, which was the epicenter, and in daily cases in Hubei province, in which Wuhan exists, which is also the epicenter province. You can see the estimate on the lower right in D there, not the lower right, but the D panel of what our reproductive number was with the uncertainty around it. And then on the lower right, what you're seeing is the spread, which shows you our simulation of the number of cities with cumulative incidence greater than 10 persons, and we capture that as well. Now, because it's a model, we can also play around with it. We could say, well, what if we were to take these same parameter estimates except adjust mu, which is this contagiousness per person for the undocumented infections, and suppose we were to shut that off. If we set mu equal to 0, that means we're saying that the undocumented infections, those who have not sought medical care, are actually not contagious. They're not infectious. They don't go through a period where they themselves can transmit the virus. And if we do that, you can see the differences here from the blue compared to the red, which was the simulations you saw before in the previous slide. What we can see is, in fact, that this greatly curtails the outbreak, and that without these undocumented infections, 80% of confirmed cases disappear. What it means is that the undocumented infections, even though they're less contagious per person, because there are more of them, they are driving the outbreak. They're responsible for the lion's share of the transmission, and they're what facilitating the spread of this virus and the movement of it through Chinese society.
5 more minutes.
Well, thank you. So it's worthwhile stepping back and taking a look at this in the context of other coronaviruses. So we have 6 other coronaviruses that have actually infected humans. SARS-1, which emerged in the early 2000s, was very severe. It had a very high case fatality rate, but it didn't produce subclinical infections. In other words, there weren't people who were undocumented infections. And we know this because they've done serosurveys looking for antibodies shortly after this thing arrived, and they couldn't find people who had antibodies against SARS-1 who had not been a documented case, who had not sought clinical care and diagnosed during the actual clinical stages of it. So that virus wasn't able to get around because it didn't have the characteristic of having a lot of these undocumented infections who support stealth transmission. MERS emerged in the 2010s, and it too was like SARS, but it also wasn't as transmissible. It did have some mild or asymptomatic infections that were undocumented. It's estimated about 20%, but it didn't transmit as well. So it wasn't able to get around as easily because of an innate characteristic of it not being as transmissible, and its transmission was more isolated to households and hospital environments. On the other end of the spectrum, we have these seasonal or endemic coronaviruses that go by these 4 alphanumeric names you see listed in parentheses. And as I showed you in our Virome project in New York City, we documented about 135 infection events from these viruses. The majority of them are mild. This is a virus that produces very mild and mostly asymptomatic infections in people, all right? And only 4% of people who were infected actually sought medical care. So this is the other end of the spectrum. What we're seeing from our analysis of what goes on in China is that this virus lies somewhere in between. And it unfortunately has the critical features that made it really destined to be a very bad pandemic. As a matter of fact, the worst that the world has seen for a respiratory virus since 1918. And those are the 3 following features. 1, it is emergent novel respiratory virus to which the majority of the population is susceptible, and susceptible people are dry kindling to a fire. The second is that the majority of infections are subclinical. People do not seek medical attention in most instances. They're not aware that they have the infection. And as a consequence, they're out and about in the community and spreading it readily. We also were able to see in our analysis, by the way, that there was considerable pre-symptomatic shedding of the virus as well. So we have asymptomatic shedding and mild symptomatic shedding of people who are unwittingly sharing the virus because they simply don't know they have it and they're not curtailing their normal activities. They're out and about in the community. And further, we also have for people who will eventually see a doctor, a pre-symptomatic stage where they are shedding, but they're not yet manifesting with symptoms. So they also have not slowed down. You put these things together and the virus is very well supported by silent or stealth transmission by people unknowingly sharing it. The third characteristic, which of course makes it dangerous, is that not everybody is subclinical. And even though the majority are, there are a substantial number of people who will need a doctor's care and will have critical complications, and there's a substantial case fatality rate associated with those individuals.
2 minutes.
Thank you. So since looking at this analysis in China, we've also looked at other locations with a big focus on the US, which is where we're based. And this shows you what happened with US confirmed cases, which first arose. The first one was towards the end of January, and then we had a little dithering along with just stuttering chains of transmission and not much recognition of what was going on. And at the end of February, it just started to take off. We took a similar model and we applied it on a county by county basis to the US. We used travel patterns that were documented from commuting data from US Census surveys. And we did the same exercise estimating what was going on in the US in that initial phase through March 13th. And we got very similar estimates, except note that the reporting rate dropped from 14% to 8%, meaning instead of 1 in 7, only 1 in 12 infections was documented. And this is consistent with the fact that the US had much more limiting testing, and they were restricting people who could be tested at the time to those who had direct contact with people from Wuhan or had been at Wuhan themselves, a bit at the epicenter. We also, since then, have done a number of things with this same model where we've allowed the characteristics of it to vary. So instead of having a single beta, which is the contact rate for all counties in the United States, or a single ascertainment rate or reporting rate alpha, we allow those parameters to vary through time, and we also allow them to vary geographically. We've also taken in assimilation, not just of cases, but also of deaths. We've added a number of other features to the models that we're using. One thing we've done is we've done an inference fitting and projection for all the counties that had more than 400 cumulative cases in the US. We also included all the other counties, but they were grouped into sort of lumped estimates of beta, as it were, in this instance. What we were able to do with this is that we were able to fit the model to what had been observed, as what might be expected. You're seeing cases on the left, deaths on the right, nationally in the top row, and for the New York City metropolitan area, which is about 12 counties, in the middle rows. We also could get time-varying estimates of the reproductive number over time on a county-by-county basis, and we could see how things changed, and individual locations followed different trajectories as a result of the different policies and practices put in place by each of these communities. In other words, within the United States, we didn't have a centralized policy. We had different policies imposed by different governors and mayors throughout the country. And that could vary from school closings to shelter in places to encouraging people to wear masks. We also had different rates of compliance among the population to that. All those are going to manifest at different rates of decline of the reproductive number, which also may start from a different point because you have different rates of mixing, use of public transportation, et cetera, and population densities, for instance. So the trajectory that New York followed, and that's the metro area, is different from New Orleans, and it's different from LA and Chicago. And we can measure and estimate each of those with our fitting and inference. So one of the last things we did is we said, well, what would happen if we had done the exact same policies in each county as they heterogeneously and individually undertook them based on the policies implemented and the public compliance, but we walked it back a week. We did it 1 week earlier. If we'd gotten our act together just 1 week earlier or just 2 weeks earlier. So we take the controls that we estimate in that reproductive number on March 15th, we move it back 1 week to March 8th, and we move it back another time 2 weeks to March 1st. And what you can see in the X's are the actual observations for national and for New York City, for cases and for deaths. And you see in the gray, the median estimate, the interquartile range, and in the lighter shade, the 95% prediction interval for this counterfactual simulation. And you can see something that is actually somewhat intuitive. The earlier you act on an exponential growth process, the better your results are going to be. So if the US had been able to implement these changes as they were heterogeneously implemented, just 1 week earlier, there's over a 50% reduction in cases and deaths as they would have manifest as of May 3rd. We took it through May 3rd because that was the point when a loosening of restrictions rather than control was taking place, and it represents a period of time during which there was a continued effort to ratchet up control. Now we also can look at this going forward, which we did at the time, which was to say that this applies for rebounds no matter where we're seeing them. We have a large pool of susceptibles remaining in the population, and it's critical that we keep up surveillance wherever we are so that when we have flare-ups, that we're able to jump on them early. And the earlier, the better, because even a 1 week delay in the response is going to result in a much higher rate of cases, much higher rate of deaths that are going to have to be contended with. And so it's really critical that we maintain our vigilance against this virus, that we keep up our public health controls and recognize growth as soon as we can when dealing with it. So I will stop there, and I'd be happy to take questions as deemed by the moderator.
That's great, thank you. And as a reminder, just put your questions in the Q&A box. So we have one question to start off. Your R0 seems to have been rising in Miami near the end of your period. Is that why in May and June there was a spike there?
Yeah, we do see that in a number of locations. You know, Chicago, for instance, brought it down but never got it below 1. And they had a real problem in late April. They had a very large outbreak there at the time because they hadn't fully gotten it under control. The R=1 line is the critical line epidemiologically, where you're going to see the dividing between growth when it's greater than 1 or actual control and contraction in the locality. So where we see it go above 1 is problematic. Now, within the United States, the context was very problematic in the sense that at the end of April, beginning of May, this is a period of time when a lot of the governors in the country, governors of states, relaxed control efforts. They allowed businesses to reopen, they allowed events to take place, and as a consequence, they were encouraging mixing from a point where they hadn't fully gotten it under control. We could see at that time in early May that there were lots of counties that were marginally below 1, at 1, or above 1, and yet they were opening up activities in these, which was not where they wanted to be. Further, they hadn't really driven the number of cases, the incidence of the disease down low enough. Instead of having 20,000 cases a day in the United States, it would have been much preferable if we had driven it down to 200 cases a day before opening things up and started from a position where very low incidence, very low numbers of cases on a daily basis reported, and that reproductive number below 1 considerably. That gives you the wiggle room and the control to keep it under control when there are flare-ups through test and tracing.
Thank you. Now we've got 2 questions that relate to testing. First one is, could you say more about how testing capacity constraints and the analysis found estimates about your degree to which milder versus more severe cases get tested? For example, testing of severe cases is assumed to be prioritized because with severe capacity constraints, most testing capacities within hospitals, or is that part of the estimation design? And then the second person asking related question is, what are the policy implications for control of COVID-19? Would you recommend mass testing for the population?
So I think the first question is getting to how are we dealing to the fact that testing policies aren't stationary and that they're moving over time. And in the United States, we deal with that by allowing that alpha parameter to vary through time. So the reporting rate is going to differ depending on the rates at which people are seeking care for the virus. And as it becomes more prevalent, people know about it, they're more likely perhaps to go and get tested because they're concerned about it. And it's going to vary as testing capacity varies. And there have been points in times where there have been choke points where we haven't been able to test as many people as we would have liked, at least in the United States. It certainly occurred for many other countries as well, maybe not to the same extent or in the same fashion. So by letting that alpha be something that we estimate, we can see differences in reporting rates, and we did see them fluctuate over time. And we went from 1/12 up to 1/5, then back down to 1/10 in some places. And it's very heterogeneous, and it seems to map with what was available at the time. So certainly you're going to see variance there, and that's something that we would want to keep an eye on and understand whether or not the reporting rates as we're estimating are varying in a way that's in concert with what we know is happening with testing practices and the availability of tests. In terms of using it for control, I personally think it's a very effective control for getting a handle on COVID-19. However, the United States, for instance, in its current state of having 60 to 75,000 cases a day, is never going to build the capacity in timely fashion that's going to allow them to test and trace that many people, the tracing in particular I'm talking about. It's very effective if you can jump on it early. If you can crush it down very low, let's say as South Korea has done, you can use testing and tracing to keep flare-ups in check. You identify the flare-ups, you do this cluster busting activity where you go after them and you go into people's, in the instance of South Koreans, they go into people's credit cards, they go into video surveillance, they go into their cell phone records to find out where they are. And they use that to help identify where they've been shopping, where they've been going out to restaurants, because those are open in South Korea, and who they may have exposed there, quarantining those individuals and testing them to find out what's the extent of the spread. It's proven effective to actually control the virus. Now, it's not the only strategy, but it seems to be a very effective one. But it's very hard to implement from a position when you have up to 75,000 cases a day, because there are just too many people to trace at that point and to test their contacts. That's when it really puts a strain on the system because the manpower is not there. So yes, testing and tracing can be very, very effective, but it has to be coupled with other non-pharmaceutical interventions such as social distancing, mask wearing, and in some cases, the restriction of business activities, shuttering of businesses, restaurants, et cetera, and the limiting of mass gatherings.
So we have time for one last question, and that was whether you and your colleagues had a discussion around the immediate closing of U.S. borders with quarantine.
You mean the one that actually took place?
I think the question's referring to in the current discuss recommending an early immediate closing.
Well, the thing about borders is that there's sort of been a dogma in epidemiology that restricting travel doesn't work against respiratory viruses. On the other hand, I think China showed that it can. If you are, frankly, draconian enough and you can seal it off enough and you can restrict a movement efficiently enough, it is an effective means for stopping the spread geographically of the virus. But it has to be almost airtight. You can't let much in or out. In a place like the US, that hasn't been possible to have that level of restriction. Certainly within the country, that has not happened. With the borders, you know, it can stop and stem some of the flow in, but the reality is what we're dealing with here is locally sustained transmission. The fact that the US has 75,000 cases a day has almost nothing to do with importation. It has to do with transmission within the community within the US. And that is of paramount importance. We have to control that first and foremost. On the other hand, the fact that Europe, for instance, is now banning Americans from coming over to Europe, there may be some sense in that, particularly in countries that have it at very, very low levels, to actually restrict the movement so that they don't have to risk import and they don't have to do the levels of screening that you see the Chinese are doing right now to control the amount of importation into their country of COVID-19.
Thank you very much, and please join me in thanking Jeffrey Shaman for an excellent presentation to kick off our conference. Our next speaker is Naveed Ghaffazadeh, is an associate professor at Virginia Tech University. Naveed's research interests include system sciences and application of system dynamic modeling in various managerial and policy contexts, such as service enterprise, higher education, science policy, and health policy. He's also been involved in the Institute in System Science and Health, and his research has been supported by various organizations such as NIH and corporations such as Dell. Naveed is also an associate editor of the System Dynamics Review. Please join me in welcoming Naveed.
Thank you, Peter. I'm reporting on a COVID-19 modeling project. This is a collaborative work with my colleague and friend, Haji Rahman Dad. Okay, so during the past several months, we have been learning a lot about COVID-19 by several different research projects all around the world. And, but there is still a simple and yet puzzling question that remains. And as time passes, we learn that this is a very difficult question. And that's about how many people are infected. And as you think about it, and as you heard in the first presentation, it is a challenging question to address, and also it is an important question. And within the same line, you can ask the question of how many people have died from COVID-19. And that's also a challenging one because not everybody who has died are confirmed by tests before the death. So think about these questions, and from policymaking standpoint, we like to have good estimates for that because we are dealing with several important decisions. We like to know how fast the disease is spreading. Are we close to herd immunity? How much we should allocate our resources in different locations for testing, and how long we should continue our social distancing, how long we should have our schools closed. So this is a very critical question. And it is important to note that underestimation of the cases is very dangerous because people's behavior is influenced by how numbers are reported. They are hearing and they are perceiving the risks by what they are hearing in media, and that's influencing their behavior. So that can influence how they are interacting in the society. So it's a very critical issue. Why it is hard to have a good estimate, it goes back to the tests, and we know that all these tests are not 100% accurate. There are many cases that are missed. Operationally, there are delays in testing, and also there is a pre-symptomatic duration that takes time for somebody to get tested, and all these situations when you put them together, including the coverage of tests that is not perfect, and in different regions of the world, is just it varies, and in some places there is not enough tests. So you put all these together, so we are dealing with a phenomena that we are having very imperfect observations from that. And as I said, these observations are changing the phenomena. They are feeding back to people's behavior, and that's influencing how the disease is spreading. That's influencing how the government is making decisions, which is also feeding back to the disease, the speed at which it is spreading. So we are learning as things are happening, and it is a very timely issue. And with all these complexities, we know that as we are learning about these issues, people are dying. So we always deal with complex issues. We always deal with estimation problems. But the problem here is that this urgent problem, and people's behavior is influenced, and that's important to move toward offering good estimations of the issue. So our objective in this project was to offer a model-based estimation approach to help understand the spread of the disease. So we are, so given that tests are not perfect, how can we have a model-based estimation that uses all available sources of data and combines them to give a better estimate of the situation? The case that we focused was Iran's case. Iran was one of the early epicenters of the disease. The first confirmed cases were on February 19, 2020. And the country had limited preparations because of all the economic situations that the country is dealing with. And it was very kind of, we felt there are very inconsistent information cues that are coming from the country, and it was very alarming. The estimations that I'm offering here are based on the paper that came out on March 20th. So it is 1 month after the first cases of confirmed cases came out. So think about like the 1 month duration for using all kind of uncertain data that are available to have an estimate. To motivate this study, this is a message that my co-author received from a friend in Iran that was working in a hospital that they say in an hour, in one single hospital, 17 people died, and doctors believe that their deaths were linked to COVID-19 through CT scans or other indicators. And it is a huge kind of issue in the hospital, and people are panicked and doctors are thinking about quitting. And then you put that 17 people death in 1 hour in one single hospital with the aggregate data that is officially reported, which is 19 deaths by that time during the 7 days. You see that inconsistency, right? So the question is, what is happening here? If you plot graphs over time of number of infected individuals by then, so the first 2 deaths are on February 19th, and the numbers are growing as they are reported. But then there are also other indicators that we should consider them. So one of the kind of conventional mechanisms to estimate number of infected people is to look at travels, right? When from a country that is infected, people travel to another country, and upon their arrival in airports are screened, you can have an estimate of, based on the probability of traveling, an estimate fraction of traveling and probability of infection. You can estimate number of people that are infected in that country. So there was a study that came out and said, well, these numbers don't match, and it should be around 18,000 infected. And you just can compare that single data point with the trend. Other unofficial reports came out from CT scan and medical diagnosis from hospitals that they're showing similar inconsistency in death numbers. Around February 26, one report came out with 210 deaths. Again, you see the gap, and then the next reports still were showing gap between official death counts and the trend that was reported by clinical diagnosis. So we were interested and we felt it is very important to learn what is going on to help the situation. So our approach is building a dynamic model, and in that regard, we follow the conventional SCIR models, but we add behavioral responses to the model because of the mechanisms that I mentioned initially, that people respond to the situation. Then this is like model-wise, but we also use estimation techniques to have kind of estimates for our parameters, for unknown parameters, because the problem is going to be about estimation of cases. So estimating parameters will be very important. And then once you calibrate your model, estimated your parameter, then we can also look at the trajectory in the coming month. So this is the basic structure of the model, which is following the conventional SCIR models. We have susceptible, we have early infected, late infected, and then recovered and death. Early infected are the ones that are pre-symptomatic or asymptomatic. And then late infected, a proportion of them are symptomatic, and the rest are asymptomatic. The common infection mechanism exists. So a proportion of early infected are among infectious individuals and can infect new individuals. And we have late infected. So these, the pattern of infection or the power of this infection is also a function of contact rate, how individuals are contacting each other. So as I said, a fraction of late infected are symptomatic late infected. And we find how many are symptomatic based on the fraction that are diagnosed, right? A proportion of those people who are symptomatic and late infected will be confirmed infected, and the ones that are dying will be our confirmed death rate. And the assumption that we are adding to this model, so overall, so far it is a generic model, but the assumption that we are adding here is that this contact rate can depend on confirmed death rate. So the idea here is that public perception of the risk of the issue will be influenced by number of confirmed deaths that are officially reported and through media. There are other ways of modeling this, like what if it is a function of confirmed cases? We have looked at different ways, but it feels like if many people are being infected but nobody dies, it won't be that much of a public health risk or perceived by individuals. So we formulated it as a function of confirmed death rate. The second modification that we have in this model is that testing rate that was raised in the previous presentation too, we are modeling that endogenously too. So government is also responding to how severe the situation is by changing its test coverage. So that's the second addition that we have. So with adding these two endogenous mechanisms in this model, we also look at other information cues that exist in the society. So as I said, in addition to confirmed cases that are coming from the government, we have unofficial death rate that are coming from clinical diagnosis. Not many data points, just a few, but still we can track them in the model. We have early on, before closing airports, we have some diagnosis upon arrival, and we can also have that in the model. So once you have this model, your reproduction number, first of all, is endogenous. It is changing in the model based on how the situation is evolving. And then coverage of the test is also changing endogenously in the model. What do we need to know? The question in this research is about these 4 variables. So we like to have estimations of these 4. What do we have? We have data on confirmed infected, confirmed death. Also, we have confirmed recovered. I'm not showing that in this picture. And on those unofficial numbers that will be useful for our estimates. This is a very simple view of the model. The model has more details, operational details that are documented in the paper. We take parameters from published papers and putting all these together, so we have 9 parameters that we need to estimate from model calibration. So we use these data sources and adding those estimates from passengers, infected passengers, and cumulative death of healthcare system report. We use maximum likelihood estimations, and based on Markov chain Monte Carlo, we assess uncertainties in our parameters. And the idea is that you have the model, you fit it with the data, and then you find parameter values that can replicate the data. And because there's lots of uncertainty, we are looking for joint distribution of those parameter values that can create the data that is observed. Once you find those joint distributions, you can plug in back those into your model and simulate them with those and look at the variables that you wanted to have good estimations for that. That's number of cases. So these are our results. The first 2 graphs shows how the model is replicating the past data. So the one on the left are those official reports, recovery, cumulative infected, and cumulative death. And the one on the right are those unofficial numbers that we're also tracking them in our model and trying to replicate them. Then we plug in those parameters that we got, joint distributions to our model and simulate all of the situations. And we look at the distribution of numbers that we are getting for cumulative infection and death. And this is where results become surprising. We find that the number of infections should be 50 times more than official reports. So that's like 2% of the cases are reported. And on death, it is about 11 times more than official reports. So that's very alarming and makes one worry that the situation is not good. We also look at other trends. We look at models estimation of reproduction number. As you see, the reproduction number is endogenously changing. It's going down because contact rates are changing and people are responding to the situation as time passes. So having the model, we do policy analysis. We have 3 scenarios for temperature effect. Back then, we didn't have good estimation for effect of temperature. Later, Hajir and I, and with several other colleagues, did a research on that topic too. But we have, in this paper, we have 3 estimates for 3 scenarios for weather effect and 2 social distancing policies. So one is just leave it to the society and kind of naturally reflect to issues that are happening. And the other is more aggressively stop interactions. So 3 and 2 will give you 6 conditions. And you run the model for those 6 conditions and look at the trajectory. So what we are finding here is that the reproduction number is going toward 1 and then staying around that number unless we get to very optimistic scenarios about temperature and government aggressively stops interactions, which actually didn't happen as you look later to the case. But these are the estimations that we are getting for the model for its future trend.
A little under 5 minutes.
Thank you. So this was the analysis done around March 20th and came out in meta-archive back then. And now it is published in System Dynamics Review. But since then, we have had much more data. And when we are talking about like a problem that has been around for a very short time, this few months means that you have 4 times more data. So we have now much more information about the situation. And in all these cases, as you predict the future, you have like a wider range of uncertainties, right? But as you estimate things that are happening around the same time, you have narrower, and when you look at the back, you have a much narrower estimates. So we found, looking back at what happened then on our estimates, we find that we have more evidence in support of our estimations for COVID death than cumulative infection estimates, since we did better in the death estimates. Official reports, if you remember, was 1,400 death and about 20,000 cumulative infected. Our estimates were 10 times more than, or 11 times more than that. And for cumulative infected, about 46 times more than official reports. Later on, 2 studies came out. 5 weeks later, there was a testing study in 1 province. They actually found more than what we estimated for infected cases. So, which is interesting, but it was in 1 province. The other data that came out with a longer delay, was a 7 weeks delay, was for all-cause death data. That's the data that countries report for all cases of death, and then you use that to estimate deaths that are related to COVID-19 based on excess date. And if you use that, you get 7 times more than official reports for death. And that 7 is in our confidence interval of our estimates. So very able to report future testing rates. That's important, that helps us to see if you are reporting future official reports too or not. Again, we were more successful in replicating official reports of death than cases. So the data for 1 month, used, and then we simulated that model for the rest of the period. We see that the model was doing a better job for estimating death cases than infectious cases. And looking back at what happened, we see that the test rate in Iran changed so much that our model wasn't able to capture that. So one of the lessons that we learned was that the testing side of the model, the formulation for that can further improve to endogenously replicate government response to all these situations and pressures to improve testing capacity.
2 minutes.
Thank you. So our estimates, in short, were 1 order of magnitude higher than official reports, and post-analysis reflection showed that death rate was better estimated. And what we learned is that the testing substructure of the model can be improved. Next study recently came out by Rahman Dad and his colleagues that kind of expands the testing substructure to better capture global spread of the disease. The problem of undercounting cases of death is not limited to Iran. So there's a lesson that can be learned and used in different countries, as you have seen in different media reports. This is something that is everywhere, including United States, Britain, and all over the world. So these type of techniques can be used to have better estimates for the cases. In this analysis, we were dealing with modeling in real time of a complex problem. As I said, people are dying, so you don't have time to kind of go and spend on modeling. So it is all about timely response of modelers, right? And it makes it challenging. Another issue that we should be very careful is about all those uncertainties that exist in in data and in this problem. So in order to have a useful model, we need to use any available data and use all, kind of estimation methods that might be proper for our modeling to have better estimates in our model. Without appreciating all these uncertainties, our estimations might not be that useful. So we need to improve on that dimension. Finally, the modeling side of the problem is very important. We need feedback-rich models that include behavioral responses. Without including how people are responding and how government is responding to the cases, then future projection might be very off. And those, you may get like very off bad, worst case scenarios in your estimates. But by including how people are responding to the cases, you kind of model social distancing as a part of your model. Thank you for listening to this presentation.
Excellent. Thank you for your presentation. And we have time for a number of questions, so remember to put them in the Q&A box. The first set of questions a number of folks are asking is around communication of results to policymakers, and in particular, what's the smallest SD model you find works for most effective communication?
Thank you. By the way, Hajir also, welcome to join if he wants to answer. This paper particularly received a wide range of public attention. It was reported on BBC and several other news outlets, and officials in government saw this report, and we think that it influenced people's behavior and hopefully helped with kind of having a better estimate of the situation. Then small models are often very powerful models for presenting the insights. You always have the trade-off, how much details you want to have to your model to have better estimates, or versus how you want to communicate your model with the audience. And we are kind of believers that what is important is to have dynamic complexities in your model, and about the details, you should stay with the details that are kind of essential for the purpose of the model.
A question about referring to the timeliness of modeling and results. Do you think that scientific journals should adapt to the need to updates to articles that have already been published for topics that require timely results?
I didn't get the question. So regarding the...
So the question is about for work that has already been published in a pretty dynamic situation. Do you think journals should have a mechanism to update the results?
Well, I think we should kind of in outlets like medRxiv and those places, you can update your results, right? So that's where you kind of correct if there is anything wrong. But there's another aspect of the problem is about uncertainties. It's much easier to 2 years from now estimate like what were the cases today, right? But in reality, what is important is to make predictions and estimation as soon as possible. So there's that part of the reality, which is something that we should learn. So I believe that we should have timely estimations, but it's also good to have reflection on what we learned from those estimations, their accuracy, and how we can improve our future estimations.
Another question, building on uncertainty. Uncertainty is often used to delay actions. With data from Wuhan in late January, didn't we know enough to enact strong policies to keep exponential growth in check?
I agree that uncertainties are a major barrier for decision making, and if you include all kind of many behavioral decision making biases about when you're uncertain, you kind of go with the status quo and delay your actions. It makes things very difficult. And if we knew what we knew, that's always I know it would have been helpful, right, in any situation. But we are using these techniques to kind of go around that.
And just to be clear, there was no data coming from Iran until late February. Whether anybody suspected the magnitude of epidemic in Iran sometime in February within the government, we don't know. There are signs that at least there were reports from doctors that something is happening, but definitely nobody had any idea of the scope of what is happening. So I don't think before mid-February there was any indication to alert people to start doing the type of analysis that is needed.
Great.
Yeah, we have done some supplementary analysis, like looking at how people are searching, right? You look at how people are searching coughing in the country in different cities. You see some associations, but it doesn't go like very back, kind of estimating when the disease started. And then kind of, I want to second what Hajir said.
So we have another question here concerning documentation, the trade-off between documentation and getting results off. So one of the issues we have seen with COVID-19 has been the quality or lack of proper documentation, and recent research shows that about 25% of models didn't even report the model equations, and authors often respond that they wanted to share results quickly and so didn't have time for documentation, but that was has major consequences. What was your experience in this project, and how did you deal with the trade-off between full documentation and rapid publication?
I mean, the trade-off that they picked was full documentation. So we went with the extreme of documenting all details of the model, making any data available. And this was easier for this project than our weather study, which had like much more modeling details. But I'm sure that Hajir would agree that we should always go with the with documentation practice, do it in a way that everything can be replicated in our models. There is a good article by the next author, by the next presenter, Nate, on the topic, and his colleagues on the importance of documenting everything that is done on COVID-19 modeling, because because we are all learning this together, right? We should try to share our models and make it making it scientific means that it should be scientifically replicatable.
And I would add to that, there is no trade-off, absolutely. I think the process of documentation is so key in you yourself making sure everything is in place and correctly done, that I see that as a quality control part of the process as well for your own benefit. So I don't think there is even a trade-off to start with.
So that let me ask a question of my own then. So I think that's great, and that's what we stand for in system dynamics and modeling. So maybe given that people are, expressing this sort of trade-off, what are some of the more specific strategies that you use to make it work? I know Nate has done some work along these lines, but anything you could advise for somebody starting to get into modeling about documentation? And Hajir, you've also written on this.
There are a few tools for documenting, but we can think in terms of you can simply think about it as making the model all equations available, all parameters available. So it is about formulation of the model that should be available. It is about coding of the model that should be available. About parameter values that you found, they all should be available. Also, in addition, you should document how each figure that you have in the paper, or in general, how any experiment that you have done in your simulation is done. Like, what is the parameter that you're changing, how much it is changed. So everything should be documented in that regard, so people use it. I think we all kind of like the steps are not that difficult. The issue is that it's hard to document all those cases and kind of do it. But as we learn that this is important, this is very critical to do, I think we can all do it.
So I would add a couple of items. One is the documentation should be built into the process of modeling. It's not just a throw off to the end of the process. To the extent that you can get to a one-click solution, that you have coded everything, it's an automated process, you actually have built into that code much of the documentation. It's just kind of having enough comments and clarity so that a third party can easily follow what you have done. And if that is the process to structure the task allocation within your team so that you get to that kind of a single click solution, that's very helpful for your team as well, because everybody can then kind of get control and kind of transfer responsibilities. You have to have modular pieces for your code and so on. Kind of the traditional way some we used to do modeling in system dynamics with kind of build a single MDL file and do manual simulations would not scale if you are doing millions of simulations and doing all kinds of complex estimation work. So it is important actually to build in the process of modeling what you need for documentation. But much of that effort is actually helping you take care of the quality of work and modularity and the task allocation in a larger team. And the ease of documentation becomes a kind of a byproduct at the end.
Excellent, thank you. And that's great advice for especially people new to computational modeling. So please join me in thanking Naveed on a terrific presentation. Our next presenter is Nate Osgood. He's a professor in computer science with associate faculty appointments in departments of community health and epidemiology and bioengineering at University of Saskatchewan, Canada. He has a long history of public health modeling and policy going back to his early work in tobacco policy, work on STD contact tracing, and most recently he's been very involved with local health authorities in their response to COVID. Many of you also know Nate from his summer boot camps in Saskatchewan on modeling complex adaptive systems. Please join me in welcoming Nate Osgood.
Thanks so much. Just wanted to make sure the audio's working okay. I had to relocate my my audio recording here. Okay, great, thanks. So it's a great pleasure and honor to be with you today to share with you some of our work in leveraging hybrid dynamic models for COVID-19 strategic and operational decision-making across Canada and across indeed the world, but with a particular focus on our home province of Saskatchewan. I delivered this talk as an academic and head of our computational epidemiology public health informatics lab. But it's also predominantly in my capacity of service to our healthcare system, in which I serve both the Ministry of Health on the one hand and our Saskatchewan Health Authority in a seconded full-time position since the beginning of March to co-direct the work involved in confronting the challenges of COVID-19. And so while this work does have an academic component, it is predominantly one that's aimed at directly addressing the needs of our decision makers and our communities throughout our province. I need to begin, however, with acknowledgements reflect in that context. Acknowledgements for our lab, many of whom are shown here, and you'll get closer introductions to some of the students throughout this talk. And thanks to our Health Authority and our Ministry of Health for making this work possible. We do report on a regular basis, typically one or more times a week, to our Chief Medical Officer for the province, and we have oversight from both the Ministry of Health on the one hand and the SHA at the topmost level. Our embedding within the healthcare system helps ensure unimpeded data flows to inform the sorts of modeling shown here. This work is providing guidance at everything from, in the earliest stages, capacity planning, through to outbreak response, reopening measures, resource planning, such as for PPEs, personal protective equipment, and messaging communication to the province as a whole, as well as particular communities. I need to thank also my fellow presenters here for their excellent presentations, which are in many sense complementary with mine. This presentation will be geared to presenting a diversity of work rather than the depth on any one topic, but many of the methods featured within the previous work, particularly its meshing of Bayesian methods and dynamic modeling, help better set a context for some of the elements that you'll be seeing in my talk. Our work, whilst it's geared first and foremost towards the needs of our province, and it was in that capacity that I cut short my sabbatical at Harvard School of Public Health to serve our province in this capacity, is also directed to address needs from collaborators across Canada, our central government, provincial and territorial level, and also international partners, most notably those in Australia. This work is part of a bigger milieu of broader analytics, co-led by myself and my co-lead, about whom I cannot express strong enough appreciation, Dr. Jenny Bazarin, the Senior Information Officer at our Health Authority. This work does bridge things such as social media analysis, smartphone-based analytics, drawing on our longtime work in these areas, with dynamic modeling, machine learning, and computational statistics. And there's 4 fundamental types of modeling that we make use of within this work. They're shown here in different of the vignettes. The 3 vignettes I'll be showing highlight different combinations of these work, true to the term hybrid modeling. And those 3 vignettes I'm going to be talking about are shown here. The blue ones represent lines of early modeling work that are now no longer actively developed, more abundant as it were. But the 3 additional elements I'll be walking through, including edge-based modeling, adaptive Bayesian modeling based on particle filtering, sequential Monte Carlo processes, and then finally scalable hybrids of compartmental on the one hand, system dynamics, and then on the other, agent-based and discrete event simulation. The first of these joins together agent-based modeling and discrete event simulation for a GIS-informed model, with the GIS being key for informing buy-in and geographic understanding relevant to the particular communities model. This has been applied at the urban level, at remote and rural communities, such as those in our far north of our province, some of whom have been hard hit by the spread of infection. The model goal here is to help us understand and help the health system, public health and acute care, understand the relative magnitude and timing of health gains and resource demands associated with different intervention portfolios, taking into account, and this is key in model scoping, the key vulnerabilities associated with distinctive subpopulations, which run the gamut from our indigenous communities, such as those in our north, to those seen as concerns worldwide, seniors, those in aged care facilities of particular concern, individuals who serve in the front lines as healthcare workers, and populations that are oft neglected, particularly in much of the modeling that's been conducted in the past few months, such as the incarcerated and detained individuals, and individuals with mental health and addiction challenges, facing, for example, dual outbreaks of, on the one hand, COVID-19, and on the other, the terrible scourge of opioid related overdose deaths. Behavioral agent types in this model include a variety of active agents as well as passive, where active include persons, but other representations at a facility level. And the models, being geographically situated, characterize population mixing not only within the community as a whole, but also in particular structured contexts, such as schools, such as workplaces, long-term care facilities, acute care, homeless shelters, etc. Within particular communities, a great deal of effort has been placed on adapting this model to particular texture and specifics, demographically, geographically, in terms of subpopulations of specific communities, which has proven very powerful for some of the analytics results shared with those communities and communicated through knowledge translation activity with community members. Fine-grained public health interventions form one of the ability to conduct them forms one of the key motivations for this model. And within this context, we make use of portfolios that span the gamut from classic public health interventions such as mass testing, contact tracing, and closures, through all the way to measures focused on certain sub-communities, including the provision of homeless shelters, long-term care, specific foci, PPE use, etc. We have simple representations in this model, more complex in others, associated with acute care facilities and bear out various healthcare elements, both in acute care and intermediate or secondary care, such as long-term care community cohorting facilities to help make sure people don't infect others in their household. And contact tracing and lab testing processes are also captured, responsive to explicit requests at the community and at the provincial level to inform resourcing decisions and understand trade-offs with delays within each of those processes. In many contexts, we've adapted these in a very contextually based and grounded way to specific settings, settings that reflect local norms, the importance and interaction of mental health and addictions issues with other interventions, such as school closure, look at contingent as well as broader mask use, and specific aspects of vulnerabilities of communities, say to work site importations, say in our north. As is typical for agent-based models, we run this model on ensembles of realizations, which give us a sense not only of one expected model outcome, but of whole combinations of different possibilities. Recognizing, particularly in this dance phase, we're dancing on the edge of a knife, and stochastic variation yields markedly different happenstance in terms of some of our case numbers and risk to some of our subcommunities in different scenarios, depending on the intervention types. And much of our goals now are reducing that vulnerability, reducing that degree of variability to within acceptable limits, particularly for our at-risk subpopulations. We can do these we can conduct these outputs on a wide variety of specific outputs, and much of our work has been spent informing our chief medical officer and others of trade-offs between different portfolios of interventions. I should note here, for confidentiality reasons, this model does depend on many internal data sources. I provide here illustrative input that deliberately is taken from outputs that are not the final results of the model, so I can share more freely here. Much of our work has been spent at the community level and as well as at the provincial level, helping understand trade-offs between different types of interventions in light of different specific resourcing constraints and needs. Many points of learning have come up here because of the breadth of this presentation. I'm not going to be able to do justice to the details here, but we found a great deal of benefit from working with the local context, securing trust, buy-in, and informing an understanding that is true to local constraints and needs. And this leads to a certain nimbleness of action, whereby we've worked particularly closely with local decision makers to inform local interventions that are out of the box and take advantage of specific modeling outputs, but also the particular needs and concerns of those specific communities, and take into account the local norms within those communities. In terms of health impacts, some of the greatest impacts we've seen have been in communities where we've aligned the modeling specifics with the community textured components. I need to cite the leadership of Wade McDonald here, shown over here, as well as Kurt Kruger on an international level for their leadership of this work, and work by Winchell Chen and Young Chin that was instrumental early on with a different model that helped us our understanding of provincial needs, and as well as our understanding of particular trade-offs for interventions at a more detailed level. And finally, supporting work by Alex Dumais and Bryce Keeler for their ongoing support of this work. A second line of work meshes, like the two past presentations, elements of Bayesian modeling on the one hand, machine learning techniques with dynamic modeling on the other. And this combines classic stock and flow modeling per system dynamics practice with machine learning. And the goal here was to really responsive to questions mentioned by some of my past presenters, particularly in the last one, the need for quickly formulated models that can then be continually regrounded with newer evidence as it comes in. Our goal here is to keep model state current with the latest evidence and use that model to project forward on the basis of the learning from recent evidence. We're seeking to avoid open loop models in a way that is similar to standard practice in other areas. It would be a fool's errand for any of us to rely on even the world's most advanced weather model to predict tomorrow's weather if it were grounded only in data current as of the end of June. Instead, we make use of models that are constantly at the minute-to-minute level, regrounded by data. And so it is with our models here at a daily level. So we build models here that are grounded on a daily basis through incoming data on cases stratified by travel status, persons tested, the test volumes, as well as test positivity, the number of deaths, hospitalizations, and ICU use, recognizing that whilst the three final ones are lagged indicators, in a model that automatically takes that into account, they can provide important backstops that provide less fungible manners of estimating underlying burden. We also then, on the basis of these models constantly regrounded, do future projection. Over the years, we've made use of a variety of techniques, many of them aligned with those in the other sessions here. Our tool of choice in this case are particle filtering and sequential Monte Carlo processes, with a notable emphasis in the near future on the particle MCMC techniques that we've used so powerfully in other contexts as well. These techniques ground not only estimates of the parameter values, but through sampling estimates of the underlying state of the system. Many of those in the audience may be familiar with Kalman filtering. Particle filtering takes Kalman filtering to a much more robust level, particularly with respect to nonlinear models, calculates full joint distributions over model states over time, requires no differentiability or linearization, and it has a really computational burden well suited to public health data flows. We've applied these techniques in a wide variety of other contexts. I'm going to have to go light on this slide other than to note that in particle filtering context, we're dealing with a jockeying of different hypotheses as to the underlying state of the system over time. And there's the survival of the fittest, by which those hypotheses represented by particles that are most consistent with the evidence flourish, they're fruitful and multiply, others die out. And it's that process that allows these models to learn over time. We've applied these models at the local, regional, within the province, and provincial level, with some explorations at a national level. Test data is particularly central for mediating flows in this model, and we distinguish in this model between a frankly symptomatic pathway on the one hand and a POC or oligosymptomatic pathway at the other, and distinguish between diagnosed and undiagnosed infectives, as well as between two levels of hospitalization for COVID-19 patients. In regions that have been particularly hard hit, such as our crowded housing scene in the Saskatchewan North, we can monitor on a daily basis things like the effective reproductive number and give feedback to local decision makers. Findings which align and are consistent with evidence on, for example, a basic reproductive number consistent with what others have found in the crowded compounds of the north of our province. Also, monitor quantities such as estimates of the underlying number of diagnosed infectives. Time runs on too quickly here, and again, I'm going to have to go light, other than to say test data is key for mediating elements of this model, and we distinguish between passive case finding in both its more obligatory fashions for complications and elective fashions from those for active case findings. Formally, we have 7 different likelihoods operating within this model, responsive to the types of data, and make use of backcasting to understand earlier estimates on the light of later data, not merely cross-sectional estimates as of today in light of earlier data. We use this model for a wide variety of needs, including estimating the underlying state, something I like to refer to as population tomography, projection and forecasting, and what-if questions from the current context forward in a way that's constantly regrounded. I need to thank the leadership of Lujie Juan on the infrastructural side for his work with the processing pipeline that allows for automatic reporting to be shared, for example, with our decision makers throughout the province, and Li Xiaoyan here for her foundational work in making these models possible, building on her outstanding work in her master's thesis on pertussis and measles, as well as on chickenpox separately. A final vignette here to which I don't have time to do justice concerns a tripartite model used to support early capacity planning estimates and these days acute workflow and resource allocation for our system, and one that's grounded by understanding of risk factors and age and sex factors. This is a model that starts with a compartmental representation for mixing. At a point in the risk continuum, people bud off, as it were, into agents. They're lent to face upon a world and go through service delivery pathways, as well as have representations that capture detailed workings of the system in a way needed to inform understanding of PPE use as well as other needs. This model did incorporate representation of risk factors early on, and it's led by the formidable Yuan Tian, who also for several years now has led our modeling work for our Ministry of Health on the acute care modeling side. So how are we doing as a result? Very well compared to the rest of Canada, and I would add most certainly well, dramatically better than North America as a whole. Because of modeling findings presented early, within hours, a set of measures were put into place that I'm told were triggered in large part by those results. And those placed Saskatchewan in a very favorable position, even to the rest of Canada, which collectively bent the curve in a very strong fashion. And to neighbors such as Alberta, in particular Ontario and Quebec, we're doing favorably on both a per capita basis and absolute numbers. Diverse take-home messages here. I'm over time, and I appreciate your accommodation. Diverse types of hybrid models offer great value for planning for, preventing, and controlling COVID-19. Different models are built for different purposes, and interweaving combinations of models allow for models that are at once more transparent, more responsive to the needs of stakeholders and understanding them, more performant. Think these models where most of the population are represented with compartmental techniques and only those at a high risk are represented, for example, infectives are represented at an individual level. Scalable, effective, and indeed nimble, because we can shift the boundaries between different types of modeling. And these methods are broadly synergistic with the large-scale data collection that forms so much of our other efforts, such as from smartphones and from social media that can ground the models in ways that are rich and help us understand particular challenges for different areas of the province. So I've talked about 3 different types of modeling here. I hope those have given a bit of a glimpse of our techniques, and I'm glad to answer questions in the time that remains. Thank you for your accommodation.
Thank you. Please join me in thanking Nate on his presentation. Really excellent presentation. I have one question here. And again, folks, remember to put your questions in the Q&A box. The question is, Nate, it was mentioned in the second presentation that some policies are endogenous contact rate falls with a rise in death. What insights can you share with us on endogenizing policies in light of your work with using hybrid models?
Yeah,
As implications on preparing for the second wave and any scale downs on containment measures.
thank you very much. Yes, we put a lot of emphasis on adaptive interventions. And adaptive not only in the sense that the model is constantly adapted based on learning, but in the sense that the interventions themselves, they're adaptive strategies. They change what is undertaken. And many of our techniques there are jointly with our acute care stakeholders who, for example, want techniques that will help understand how to best inform public health decision-making in a way that reflects the downstream consequences likely to play out in the acute care settings. And at the hybrid level, with the acute care representations that we can capture, for example, in that last model type, which are quite detailed, while still keeping a model that's nimble enough for constantly regrounding, we can examine a variety of trigger strategies that throttle the degree of resourcing and identify points where, for example, elective surgeries need to be suspended to avoid local and provincial, in the future, overload of our acute care infrastructure, which even in the best of times is closely balanced and now is under stress from COVID-19. It's also something where at the messaging level, our hybrid techniques allow for very targeted messaging that's geared to very specific actionable decisions, whether by the public or by the healthcare system, whether it's gatherings of over a certain size and duration, or that have a certain looser structure rather than being fixed locations on the one hand for public, or whether it's issues having to do with specific strategies for contact tracing, for example. We can inform that decision making at a more detailed level with these hybrid models than we would be able to otherwise. I hope those comments are helpful.
Great. Another question, there are other impacts of the pandemic and interventions on society, for example, migration, daily wage income, loss of work, for example. Sort of think about broader social determinants and how they exist within feedback structures, which will in turn affect the pandemic. How do you include such feedbacks in the model, and do you think they'll help in coming up with better interventions?
Yeah, thank you very much. I think we have lots to do on this front, but we have some initial forays into this. Much of our modeling is anticipated to feed in here. This embedding of the modeling in the healthcare system, which has been so successfully tried, is anticipated not to end with the waves of pathogen, although those are expected to be significant, and our modeling suggests the need to buckle up for the fall season in this reopened context. But it's geared at multiple waves of other needs, rehabilitation needs, mental health and addictions needs associated with our economic dislocations currently being felt here and around the world. And social determinants of health really come out, not in a static sense, but in a dynamic sense, is so important as a factor here that we recognize the need to segue this modeling increasingly to better capture those medium and long-term dynamics. And much of our work on which we've embarked, geared towards these subpopulations, is aimed to do exactly that. It's understanding, for example, the needs associated with homelessness and the growing amounts of homelessness of individuals here in Canada thrown out of work from, say, the oil patch, some of whom have substance abuse challenges associated with them, by no means most. In other cases, it involves individuals in the lower S side of the socioeconomic spectrum living in crowded housing. And much of the hope that's cherished by our group, by my co-lead, Dr. Jenny Basran, and by most of my collaborators, is that COVID-19 will serve as a springboard for helping us recognize system-wide the need for working in less siloed ways, more integrated ways to leverage techniques such as system dynamics, the sorts of techniques seen in this and the other presentations, but also to join up our public health system better with our acute care system, to have a more tight combination, recognizing that my health is inextricably intertwined with those of my fellow citizens of this province, and indeed those elsewhere in the world. And that offers the potential here for resourcing this work on a multi-year basis that reflects those grander challenges and that brings together our cross-sectoral partnerships. We work very closely with those from multiple ministries, including those such as social services, corrections, and policing. They're often several steps removed from the health discussions. And it's really by leveraging those cross-sectoral collaborations and linkages that I think we can start to have traction in dealing with issues that otherwise are viewed as somebody else's business, like on the housing front or mental health and addiction services front, et cetera. Hope those comments offer some value.
That's great. That's a great response to end the plenary. We have many more questions that were asked. So let me just thank the presenters again for 3 excellent presentations. There's a great discussion going on in the chat about a number of issues, but I think one of the things we see from all 3 presentations is the importance of both transparency and documentation in this work, especially when it's going to be informing policy. And we've seen this now at 3 different scales, which is just fantastic to see. The other thing I just want to note on and to build on Nate's point, it occurred to me as we were going through the presentations how many of the modeling networks you have, and I've also been in part of, that are really part of that sustained effort in terms of funding, where people are working. There's MIDAS, there's the Computational Modeling Network for obesity work. You've been involved with Institute for System Science and Health and training grants, and that's all required to both build the teams and train the next generation and to look at some of these issues. So Nate, I really appreciate you bringing up that point. There are, again, many terrific questions. As a reminder, there are 2 30-minute echo sections for this plenary. So if you want to gather again and talk with the presenters and others, that's another opportunity. Please see the conference program for your local time for those sessions. And again, I'd like to thank the program chairs, the organizing committee, and Homer Consulting for sponsoring this thread. Thank you.